Hello, everyone, and welcome to the third episode of our podcast. So far, we've looked at how successful orthopedic surgery is and how it's typically patient frailty that tends to determine the outcome for patients, rather than surgical or perioperative care. So, today we want to look at the most common way in which patients deteriorate in the face of injury or surgery.
Yes, hello everybody. The average orthopaedic surgeon will consent their patient who comes in with a hip fracture, and they'll warn them about the very rare chance of them having a bleeding from their wound, having infection in their wound, of having a further fracture. Very rare complications, all down at the 1% sort of level. What they won't do is consent them for by far the most common complication of an orthopaedic admission, indeed of any older patient's admission to hospital, which is the development of delirium. And we know that between a quarter and a half of patients presenting with a hip fracture will become delirious. So we need to think about how delirium is handled, and that's what we want to cover today. What we need to think of is delirium as being the way in which frailty decompensates if we don't get perioperative hip fracture care correct.
And as you all know, it's not just myself and Professor Johansson doing this podcast. There's a third member, who's Grace, who we've introduced to you before, but I'd like to give you some more information about her. As I've mentioned, she's an 83-year-old. She's actually a widow as well, and she was admitted into hospital 5 days ago due to a simple trip at home, and she's had a successful hip fixation. She's now successfully been able to transfer from the orthopaedic team with us onto the medical ward. And she appears medically well. However, she does seem upset and quite confused. So what can we do about this, Professor Johansson?
Yeah, and our difficulty is that the first issue is to actually recognise that there's something wrong. When you see somebody on a ward round, often you've never met them before, and it's easy and horribly embarrassing to assume that because they're confused and muddled now, it's because they have dementia. And our challenge is that patients, families and carers will know that something's wrong, but they won't know what it is. We all know, the clinical teams all know what delirium is, or think we know what delirium is, but we just don't recognise it when it happens to patients. And unless there's conversation going on between patients, families, their carers, those close to them, and the staff working with them, we won't recognise and be able to deal with delirium. And that really is a huge challenge for us.
And I know you mentioned dementia and delirium just then. I want to know what actually each of them are. So I know there's a common misconception dementia is just simple memory loss, for example. Can you really tell me what do we mean by dementia?
Well, what did they teach you about dementia at medical school?
I don't want to put my alma mater too much in the mud, but I think for us it was basic teaching that there were different types of dementia, so vascular dementia, and other types, and how to treat it, and how I guess we can really define it, maybe using the MSE.
Yeah, and my difficulty when I sit through a dementia lecture is that I can't remember all of the vast amount of detail that there is at the end of it. My memory is okay, but how do you recognise somebody? When you're talking to somebody and to their family, when Grace's family come into the ward because she's become confused, and we talk to them, what story do you want to elicit from them? What story should we try and elicit from them to tell us whether the problem is one of dementia or delirium? And it's that recognition of the typical nature of the two that I think is really important. So if I want to elicit a story that's suggestive of dementia, I would ask somebody who knows her well, has Grace been more forgetful in the last 12 months to the extent that it's significantly affected her daily life? That's the single question in dementia. It's SQUID. It's a really clever construct which pulls in a number of things. There's an emphasis on memory in it, because memory, dementia takes out all sorts of aspects of your thought processes. But the memory is the one that people are familiar and comfortable talking about and recognising. But it's also this prolonged nature of it. Dementia doesn't come on suddenly. It can after a major stroke or something like that. But usually dementia comes on progressively over a prolonged period of time. So you're talking about something that's been there for a year or longer before people really recognise it in many cases. And having issues with your memory that are trivial is something that I suspect comes to us all as we get older. But memory difficulties that are impacting on your life are a sense of the severity that you really need to be looking for. And it's trying to tease out that story from her family that would let us know that the cognitive problems we mentioned when we first introduced Grace actually do amount to an undiagnosed dementia. And many of the patients who come through with hip fracture, the family know there's a memory difficulty, but nobody's taught about it as dementia, and they've not been offered support or services to try and help manage or indeed treat dementia. For delirium, it's quite different. The single question in delirium is, do you think Grace has been more confused lately? Again, you're asking this of people who know her. You're not talking so much about memory, but confusion is a word that people understand. You can't ask whether she's been delirious. You need to ask whether she's been confused. And the family will tend to have noticed that far before we can. But it's lately. This is an issue that's not been there for months. It's been there for days, hours, not particularly long. And you're looking for a completely different setting there. Making the diagnosis of dementia, you're also wanting to do scans to exclude other diseases, blood tests to exclude other problems. There's a whole workup of things that you need to do to exclude other treatable conditions. And for delirium, that's true as well. But it's recognition of it that's fundamentally important.
And is there an easy way that we can really get to a diagnosis of delirium, or a diagnosis of delirium?
Yeah, so in neurological teaching as a medical student, you'll have been taught how to examine the L1 nerve roots and to examine the innervation of the median nerve, little bits of wiring. But did they teach you how to examine the brain, how you think?
Not that I can remember. I might have been a bad medical student.
No, it's not done. It's completely disproportionate. Neurologists love all of these wiring diagrams, but they're not very good at explaining how the brain thinks. And that's the bit that matters. That's who we all are. So understanding that and starting to tease that out is incredibly complicated. There's so much wrapped up in it. But the 4A test is a test that everybody must be familiar with. Nobody can work with patients with hip fracture without being able to understand the 4A test. And the 4A test isn't a memory test in the way that the mini mental state or the mocker examination is, or all of those. It does include questioning whether the patient knows their age, their date of birth, and what current year is, and where they are at the moment. Those questions are one of the tests, so that's a very abbreviated mental test score, the AMT4. But it also requires that you have spoken with family, because you need, by talking to people who know the patient, to know whether there's been an acute change in alertness or cognition, anything that's different about them. Is Grace different today from how she would be normally? And you won't get that by just talking to her. You need to talk to people who know her. Change in the recent past. You also need to know whether she's alert. Some patients with delirium are very alert. They're very hypervigilant. They're very anxious about what's going on around them. But others are no trouble to us. They lie quietly asleep in bed and are not difficult or challenging to look after. But they have got hypoactive, underactive delirium, drowsy type of delirium. They're not going to be eating or drinking or engaging with therapy, getting back up and getting going. And that form of delirium is very easy to miss. It's not a challenge for us to look after, but it is very challenging for patients to survive and is really worrying. So recognizing that a diminution of alertness is a problem is key. But then the final piece of neurology that you need to examine is patients' attention. If patients don't pay attention to me when I'm trying to clerk them, I get irritated. When I get irritated by a patient, I know it's likely to be because they're delirious, not because they're difficult. It's because they're delirious. They're not paying attention. If the physio is trying to do physiotherapy with a patient who's not paying attention, they're not going to make progress. If the nurses are trying to do basic nursing care, trying to get them to engage in meals, and the patient's not paying attention, it's irritating, worrying, frightening. And that's an attention disorder. And testing and examining attention is beautifully done with this test of asking the patient to tell you the months of the years backwards. It's not something you can do from memory. It's not something you learn to do as a trick at school. You actually have to think about it and keep concentrating to go December, November, October, September, August, July, June. I can do it, but I have to think about it, and I've been doing it an enormous number of times. So this is a test I do on all of my patients. And for patients with hip fracture, it's become a complete standard.
Yeah, I was just trying to count back the months backwards. I was struggling as well as talking to you.
Yeah, so I remember some kids at school could do the alphabet backwards. It's the sort of thing you can memorize if your brain is young plastic, but actually I still have to think about it. I have to pay attention to get it done. And failing on the 4A test, there's a beautiful website for the 4A test, but failing to be able to do the 4A test is a really worrying thing. So what we've done in the UK, and particularly NHS England has pushed this, is to make it mandatory for patients to have 4AT checked when they first present and when they come back from theatre after a hip fracture. So we've got two tests of their presence or absence of delirium. And the challenge that we're putting to patients is to hospitals is to make sure that their patients don't have delirium. And about 2/3 of patients who have a hip fracture have now got documented evidence that they're free of delirium on a post-operative test. That's still 1/3 of patients who are delirious or haven't been screened for some reason. And those patients are still very much at risk, and it's hospitals where delirium screening isn't being performed reliably. Those patients are at greater risk of all sorts of things going wrong. So it's a really powerful piece of kit.
So given that there's so many patients potentially with delirium, as you mentioned, 1/3 of all patients, is the 4AT test something as clinicians, but also the whole MDT, we should be doing every single day on every single patient?
I'd love to say yes, but you're not going to do it. Nobody's going to do that. The main reason for making people do the 4AT test on hip fracture patients is to teach teach the nurses, teach the therapists how to recognise and understand delirium. It's more about educating the staff than it is about assessing the patient. And I hope that as more juniors move on from their orthopaedic wards to other wards in the hospital, we'll see 4AT testing becoming something that's standard. But the NEWS NEWS 2 score, asks the question of whether a patient is confused. So on a daily basis, on a regular basis, while observations are happening, the question's being asked, is this person confused? And I think one of the things that we need to do, and I hope this podcast will serve to do, is to help the nurses, the healthcare assistants who are working with patients doing their observations to understand the importance of recognising confusion, recognising that it's part of delirium, and that there's this whole process that we're talking through now that they need to initiate at that point.
Okay, and let's bring it back to Grace. So we know she's acutely confused. What can I, as a junior doctor, or any of the other members of the MDT really do to help her?
Yeah. So the key thing is that it's not a single thing that's wrong. In the streets of Cardiff on a Saturday night, there's one reason for people to be delirious. They're either hyperactively drunk or they're hypoactively drunk. That is delirium. But in a hospital ward with a frail older person, there are several things wrong. And you're not just going to sort this out by saying, oh, let's check for a urine infection. She's had a massive operation. She had a major injury. She's in a strange environment. She's on lots of painkillers. There's lots of things going on. You need to address all of those. And how to do that is beautifully set out in the trial that was run by Mark Antonio in Boston back in 2001. And essentially what he did was randomise some of the fitter patients coming in with hip fracture to either have normal nursing care, normal post-operative care, or to have the perioperative care and ongoing care packaged up as a comprehensive geriatric assessment. And the lovely thing about this trial is it's one of the few trials which explains really what a comprehensive geriatric assessment set out to do. So it's really well worth reading, and we'll we'll flag it in the accompanying literature for this podcast. So what he demonstrated was that the assessment each day needs to be looking to make sure that the patient's brain is getting enough oxygen. So is their blood got hemoglobin in it? Has it got oxygen in it? Has it got enough pressure to be perfusing the brain? The brain is dependent on its oxygen delivery. Is the patient dehydrated or overhydrated? Is their sugar under control? Is pain being managed? Pain management is definitely a topic we should try and do a short podcast on its own. But appropriate, sensible pain management is quite subtly important. Have we and the pharmacist looked at the drugs that people are on? Are they on unnecessary sedative medications that's turning off their ability to cope with what's going on around them? So doing an analysis of that. Bladder and bowel function is really important. If people are constipated, we know they can become confused. If people are in urinary retention, we know they can become confused. But also, for a polite, well-brought-up patient on the ward who wants to go and have their bowels open and is being pushed to try and do that in a bedpan or try and do that on a commode in a room just surrounded by other people, they often just don't want to do that. They want to get up and go to the toilet. They may not want to explain it. And I've seen countless patients in whom getting up and being allowed helped to get to the toilet and to have the bowels open just relaxes them and can solve things of itself. There's not something medical going on there. That's all psychological. Dealing with nutrition is definitely another topic for a podcast. But getting people out of bed so that they're looking not at the ceiling but at the world around them, the things in front of them, the food and drink in front of them is really important. The engagement with physiotherapy so that they can understand the purpose of being in hospital. Why am I lying in hospital? Nothing's happening. I'm looking at the ceiling. It doesn't make sense, and if the world doesn't make sense, it's really challenging. So that's 7 different topics that they covered. Before they get to the ones that we, with our medical brain, want to say, oh, it's going to be due to an infection or a coronary or some sort of medical catastrophe has happened. Actually, there are lots of other things that have happened as well. But we do need to make sure that patients haven't got some other medical condition that's putting a strain on them. But it's more important that actually the world makes sense. If the world around you doesn't make sense, if you can't see a clock, you don't have any of your possessions around you, there's nothing to orientate you, you haven't got the newspaper that you'd normally be reading, you haven't got the book you'd normally have. If things are just not there that you would expect to have around you, getting your environment wrong, if you haven't got your hearing aid, you haven't got your spectacles, you can't hear and see what's going on. So getting that sort of thing right is really important. And drug treatment for delirium is what everybody wants us to give. We did a randomized controlled trial of our patients years ago using an atypical antipsychotic, and we found benefits in managing the patients who had psychotic symptoms, but that's a very small proportion of people in whom paranoia was stopping us being able to look after them. But sedating patients, giving lorazepams, giving sedative drugs may be convenient for the staff around them, but it's not going to restore somebody's brain to the position that they'll be able to make sense of the world around them. So you've got to do all of that lot.
Okay, and I know this trial, obviously there's a lot of information about delirium. What did it actually achieve?
So in people who had comprehensive geriatric assessment, and it's a beautiful model of comprehensive geriatric assessment, they had several things were modified for each of them. There's not just one or two. There are several things that could be improved about their care, but their rates of severe delirium were more than halved. So massive impact on delirium. And as I've said, mortality in people with delirium is twice that of people without. So it's huge potential impact wrapped up in this. Beautiful paper, well worth reading, and it's a nice recipe for your ward round every day when you go around and see patients. These are things that you're doing and you may not understand why.
It's almost like a checklist that I can tick off in my mind. And for patients who are confused, is there a confusion screen that we do, or is that something of a bygone era?
Yeah, I think that is a bygone. I think talking about delirium, we need to talk about it as delirium now. Confusion is a word that you can use in conversations with the family, but talking as a team, we need to be thinking about patients as delirious. It's our problem we're confused. If we're just talking about them as confused, we sound confused ourselves. We don't sound as though we understand. So the idea that there are a set of blood tests that you need to do that will sort out whether somebody's confused is just nonsense. This is a different world. So we need to spot the medical drivers for delirium, but we need to tackle all those other things as well. And if anybody wants to learn about delirium, they have to look up Alistair McCullough's work. Alistair's professor in Edinburgh, author geriatrician like myself, but with massive interest in social media outflows in respect of his work with delirium. And he talks about all of the sort of things I've talked. He does it far more eloquently. But he also talks not about just looking after the patient's brain, but looking after their mind. And I haven't given enough credit to that aspect of the care for Grace. She's going to be frightened. Her family are going to be frightened. She's not going to know what's wrong with her. They're not going to know what's wrong with her. So the process of reassuring her, telling her that she has delirium, explaining what the scary things that are happening around her, the visions, the hallucinations she may be having, explaining all of that as delirium and reversible and something that will usually get better, is really important. And the way he talks about that, I think, is something that everybody should pay reference to.
And what's the prognosis like for Grace if she has delirium?
So about a third of people, it just goes away very quickly. A third of people, it will grumble on over some of their time during their time in hospital. And for a third of people, I think we don't see them getting back to their normal self. And teasing out what's going on there, how much there was an underlying dementia that hadn't been recognised, how much delirium leads into and exacerbates pre-existing or predicts the presence of an underlying dementing process is worrying. So yes, you can't reassure people that this is all going to go away, but it nearly always improves very substantially if you can do the really basic things.
Okay, well, thank you very much, Prof. Johansson. That was very informative. And again, thank you to you all for listening. For our next podcast, as always, we'll include all the references and links in our bio. And for our next podcast, we're going to look at how we organise the start of rehabilitation. Obviously, trying to make sure delirium doesn't get in the way, but we can talk about the average of 3 weeks and how patients start to get better. But yeah, thank you very much for speaking to me, and hope you tune in for the next one.